primary arthrodesis. So I would just like to conclude that ankle fracture is just a ring, and you have to convert this ring into a stable ring by proper restoration of the ankle joint anatomy, which you can do by looking into restoring the fibular length and rotation, and then syndesmotic stability. And you see there is no varus and valgus orientation, and the talus is fully centered into the ankle mortise, and the article congruency is maintained. So once you see all these factors, you can just put your ankle fractures back in most of the cases. So fix the fracture, including the posterior malleolus, assess the syndesmosis. If unstable, you have different choices. You can do transsyndesmotic or reattach the deltoid, PITFL, and Chapu fragment, and then do the transsyndesmotic fixation. Or you can even do the AITFL repair or reconstruction after doing the posterior malleolus fixation. So, but now the latest concept is we should try to get these fractures into position by bringing the syndesmosis in position by doing or tackling all the components of the syndesmotic injury like AITFL, PITFL, and posterior malleolus and deltoid. And that is what I've shown, what is our latest concept. And then this is the book which I've come, if someone wants to go through the latest concept, me and Dr. Sampath has contributed on the management of ankle fractures. Thank you guys very much. I'll be very happy to answer any questions if you have.
Yeah. Thank you, sir. That was a very comprehensive presentation, and we were very lucky to have this. Before we move any further, allow me to welcome none other than Professor R.C. Meena.
Thank you, Rajiv. Thank you, Kumar.
Thank you, Dr. Meena, for inviting us. You were not here. We are
Rajiv, sir, thank you very much. So nice of you, sir. I obliged with your kind presence and your vast knowledge about the foot and ankle specialty, which is really very needful part of the body. And if there is a minor injury, can I start or can I say something?
Yeah, sure.
Please
If the house is permitted. So, very good evening all. Dr. Siddharth, Dr. Upadhyay, Dr. Rahul, and Dr. Mahindra, Dr. Santanu, and my all friends, the delegates, those who are not on the screen, but they are connected with the virtual on the screen. I'm really happy, and it gives me immense pleasure to say that I have started a week of academics pre-conference in a very wonderful way. And I would like to say you that when the AGM of the IOACON was conducted on the 22nd February, it was very shockful. It was very sad that only 119 members out of 13,000 joined that meeting. But the meetings of these pre-conference workshop by different specialty, whether it was spine, whether it was arthroscopy, whether it was by the pediatrics, or it was hand, or yourself by the ankle, foot and ankle, it was joined a huge number of the delegates that proved that today in the today's world, people are not interested in the any kind of just giving the name in the association or in a association, but they are interested in the academic activities of the members of the association which are doing, like the learned faculty you. And this ankle, foot and ankle specialty is a very important part of the body. Even that if a simple thorn prick is occur in the ankle joint or foot, the posture, gait, and personality language of the patient became changed. While if a similar kind of thorn prick or minor injury occur, even in the thigh, he can tolerate it, he can walk it, and even in other part of the body. But if a simple nail avulse from the foot or a simple thorn prick in the heel or in the foot or in the ankle, his body language will be changed. So you are doing a wonderful job, Rajiv, and your team. Dr. Rahul, Dr. Siddharth, Dr. Mahendra, Dr. Santanu, all are my best friends, and I am happy that they have accepted my request to organize this pre-conference workshop on the eve of the 65th annual scientific meeting of our prestigious body IOA in the form of mini IOACON 2020 going to be held 5th to 7th March at Jaipur. And I request all those who are connected with this program and viewing this program, please attend the 65th conference of our IOA. Definitely, I promise you, you will get a wonderful academic extravaganza and you will be benefited. And by this ankle foot arthrosis workshop, I am sure the youngest, those who are not much aware about the ankle foot course and the ankle foot specialty will be definitely benefited with your this punch type of knowledge to all. Thank you, Rajiv. Thank you, Santanu. Thank you all,
sir.
Mahendra. So nice, sir. Thank you.
Kind and encouraging words. Thank you very much, sir.
Sir, you are always above than the encouragement. Yes.
Thank you, sir. Thank you. On behalf of Indian Foot and Ankle Society, it is my proud privilege to extend our heartfelt thanks to you, Meena sir, for giving us this opportunity, or giving us this platform. And we are happy to be here in full force because our past president, Dr. Rajiv Vora sir, is there. Our present president from Goa, Dr. Mahendra Kulchatkar, is there. Our Vice President or President-elect, Dr. Malhar Dave sir, is there.
Dr. Malhar, yes, sorry. Malhar is there.
Good evening, sir.
Good evening, Malhar. Sorry, वो मेरा थोड़ा सा emotion में बोल गया था.
नहीं, no problem.
Forget your name, sir. Malhar, yes, sir. Yes.
And two of our young guns, Dr.
Yes.
from PGI.
They are diamond of our Jaipur in the field of the foot and ankle.
Yes, and Dr. Rahul is also there. So we are here in full force, and we just had one of the best presentation from Dr. Rajiv Vora sir, and we shall move forward. And
is there any question, or we are going to take it, or there is?
Sir, one thing I would like to know, Rajiv,
Yep.
I see your one picture, one X-ray, in which quite is maximum, you can say, a large number of metal was put to fix the fragment of lower end of the tibia or ankle articulations. Is we can reduce the quantity of the metal. I mean to say by putting the wires or a long immobilization in the form of the plaster. Because what I want to say is this, that the soft tissue around the ankle joint is in comparison to other part of the body is less. So the plant become very easily exposed or very easily rubbed by the just touching or from the outer injury. So it is just I am not expert of the foot and ankle, but it is my curiosity.
That is the wonderful, the beauty of the posterior approaches. The two plates which I showed, one was used for the lateral part of the posterior malleolus, and the other was used for the medial part of the medial malleolus. And there is no way, there is lots of soft tissues which is covering on the back side. So that is where actually you can very safely put your implant. The only thing is we need to understand these approaches. There was a time when we were not understanding these approaches, but otherwise, on the other hand, if it comes the superficial side, like on the medial side or on the fibula, there definitely the implant should be taken. But now the concept is, particularly my concept is to start the mobilization as early as possible. So if we use, K-wires or do the plaster, the results, the stiffness is too much. So basically now we are moving towards, a good steady fixation, and we can start our mobilization as early as possible. Of course, the implants have to be used according to the soft tissue condition, according to the approach, according to the location, and of course the expertise of the person. When you are having 2 or 3 incisions around, you need to take a lot of care when you're putting these incisions, and your soft tissues should be ripe for that incision.
Thanks. Thank you, Rajiv. Nice explanation, and I am satisfied with your. My query is solved.
That Yes, sir. That was a very pertinent question from you, sir. And that has been answered very beautifully by Rajiv Vora, sir. Now, moving on, may I invite Dr. Siddharth Sharma from PGI Chandigarh, who will be speaking on tailor neck fractures and how to get them right. So, handing over to Dr. Siddharth Sharma for his talk on tailor neck fractures.
Thank you, Dr. Shantanu, sir. Thank you, Dr. Meena, sir. Thank you,
Sir, my pleasure.
Foot and Ankle Society and the organizers of the Indian Orthopedic Association Conference for giving me this wonderful opportunity in the form of a webinar. Shantanu, sir, am I audible and visible?
Yes, sir. Yes.
Audible and visible. Please go ahead.
Yes, sir, to all.
Okay, thank you so much. So I will be talking, moving on from Dr. Vora's excellent talk on ankle, we move to the talar neck fractures, which are not somewhat as common as the ankle fractures, but you do see them from time to time. And I was told that there are a lot of youngsters who see these talks. So this talk is geared towards the youngsters. And we will be quickly looking at the anatomy classification, pathomechanisms. Of course, the main course of this hopefully good dinner would be how to manage these injuries well. And we will be looking at a case-by-case example. And then I will be quickly showing you the outcomes and complications. So you know this already, talus is the second largest tarsal bone. It has 3 important articulations and 70% of its surface is articular. The principal blood supply, as we all know, is the posterior tibial artery, and the branch of the deltoid artery may be the only remaining blood supply, when you have a talar neck fracture. So when you approach these cases, you have to bear that in mind. We know about the classification, but let me just run through this. So what is a talar neck fracture? So on the lateral projection, this is the lateral process of talus. And if a fracture line runs anterior to the anterior part of the lateral process, it is a talar neck fracture, or else if it is posterior or at the lateral process, it is a body fracture. And again, we know this, quickly running through this, Hawkins originally classified it into 3 types. Interestingly, Dr. Hawkins had a great interest in hand surgery, but his life's work was centered around Hawkins classification. So originally it was 3 types. We know this. Type 1 are undisplaced fractures. 2 are the ones that had originally subtalar dislocation, but then Valier et al. Classified it into 2A and 2B. 2A are neck fractures that have displacement with an intact subtalar joint. The important part here is that there is no risk or minimal risk of avascular necrosis. 2B are talar neck fractures that have a subtalar and the risk of avian hair is 25%. Type 3, as we know, is when you have an ankle as well as a subtalar dislocation. And in type 4, you have an additional talonavicular dislocation. This was added by Canale and Kelly. Pathomechanisms, these are high velocity injuries. The classical mechanism described by Coltart was the aviator's fractures. So the foot is forced into dorsiflexion. The talus neck impinges against the anterior margin of tibia. And as there is continued dorsiflexion and axial loading, this breaks off the talar neck. Another common mechanism is forced inversion. So when you have inversion and plantar flexion, you have comminution on the medial side because that's the compression side. The lateral side is the tensile side. So you do get comminution on the medial side. When this force continues, the talus body may be wedged out, posteriorly, posteromedially. That is the most common way that it will go out of the mortise. And then you have the Hawkins type 3 fracture. So coming on to the main course of the talk, how do you manage these injuries and how do you get your talar fractures right? So workup, as we know, you have your standard foot projections. You also have the Canale view, which I'm sure most of you know how to do this. A CT scan is important to identify the location of the neck fracture, to see the comminution. Sometimes, as you can see in this slide, you have undersurface comminution, and this is a poor predictor because people who have undersurface comminution have a high chances of developing subtalar arthrosis. And in this last example, you can also see that there is a fracture, but there is a talonavicular subluxation that you need to address intraoperatively. So when do you operate these cases, the timing? So one would assume that early surgery would decrease the AVN. However, this is not the case. And this was a very interesting study which showed that early reduction of a displaced talar neck fracture, that had a subtalar dislocation, decreases the risk of AVN. However, early operation of a talar neck fracture does not result in decreased avascular necrosis. The only time you would want to go in, very early to operate these cases is when you have a Hawkins type 3 talar neck fracture, like you can see here. The talar body is wedged out of the ankle mortise. It is lying posterior-medially. It is tenting the skin on the medial side. And if you don't go in early, it may result in pressure necrosis of the skin. And how do you approach these cases? So the standard of care is to do dual approaches. Now I've seen a lot of youngsters, they say, we can do this by a single approach. Why two approaches? Well, it is so important because you need to see the talus neck from both the sides, because if you don't do that, you will not be able to assess the rotation and the varus, and you often end up in a talus malunion. So the anterior medial approach is a pretty straightforward approach. You take it from the tip of medial malleolus to the first ray. The only vital structure here is the saphenous vein. You split the medial capsule and you're onto the talar neck, as you can see here. It is important not to dissect the deep part of the deltoid, but like I told you, this is an important source of supply to the talar neck and maybe the only source of supply in a talar neck fracture which is displaced. The anterolateral approach is also straightforward. It goes from the tip of the fibula to the fourth metatarsal base. You can split or elevate the EDB, the extensor digitorum brevis. I find it easier to just split it with sharp dissection. And you can see, as in this example, that's the talar body. This is a talar head which is rotated, and you can have a good access to the subtalar joint as well. So this is a very handy approach. What are the principles of fixation? So like I told you, many of these injuries are inversion injuries. So in that case, the tensile side is the lateral side, and this is the non-comminuted side. So you can use compression screws on the lateral side. The medial side gets the compression injury, and here there is comminution. So you should avoid shortening of the medial column. And for this fixation, you can use plates or positional screws or even K-wires if you are short of your implants. So a bridge fixation is when you are using a plate on the comminuted medial side. Nowadays, they are also advocating a lateral plate fixation. And mind you, a plate on the lateral side, on the intact side, would be acting on the principles of a tension band plate. So here is a Hawkins type 1 fracture with a medial malleolus fracture. A CT, which I have not included here, showed that this was completely undisplaced. For these type of injuries, you can do a percutaneous fixation. You do this under C-arm and you can get away with it very quickly. Why would you do a fixation is to allow early rehabilitation, early range of motion for the patient. Now here is a case which is Hawkins type 2A. So there is a displaced fracture, but there is no comminution of the talar neck. You see clearly the fracture line on the CT scans. So in this case, you would do a dual approach, and as you can see here, because there is no comminution, you can use compression screws and fix it. So here is a Hawkins 2B with a subtalar dislocation. Now, mind you, this is an impressive deformity. These people will come in with a clubfoot type of a presentation. So here, the important bit is to reduce the subtalar joint if you want to decrease the risk of AVN. And how you do this? You flex the knee, plantar flex the ankle a little, apply traction to the heel, unlock the fracture, and then just reverse the deformity. And in this case, we were able to do a closed reduction. You can see that it has reduced well. The CT scan confirmed that there was no residual displacement, and then we went in and did percutaneous fixation in this case. So this is a Hawkins type 2B with comminution, and as you can see here in the CT scan, that's the fibula. So there is lateral comminution, there is medial comminution. What do you do in this case? These are difficult cases, mind you. So this is the 3D anatomy, and let me walk you through the 3D anatomy. So you can see from the medial side, this is the medial side. There is comminution of the talar neck. You can see that the subtalar joint is dislocated. The body is out. It needs to be reduced. And when you come to the lateral side, you can see that there is a lateral process fracture. The lateral neck is also comminuted. So this is a Hawkins type 2, but let it not fool you. This is a difficult injury to treat. So how we did this case step by step. So the first step, of course, is to do a lateral approach. As you can see here, the subtalar joint is dislocated in the first picture. So in this case, you can put in a periosteal elevator and gently try to reduce the subtalar joint, give some traction to the heel, and by using the lever, you can reduce the subtalar joint. In this case, it was unstable, so I had to fix it with 2K wires. And you can see now that as soon as this is done, the talus neck starts to fall back into place. Now, like I told you, the lateral part of the neck was comminuted. You need to bring it out to length. And in this case, we used a Jess fixator. We put pins in the fibula and in the navicular bone, as you can see here, distracted it, and the talus neck was brought out to length. Provisional fixation was done with K wires. And then the lateral process was fixed with screws, and we used a locking plate, a mini fragment locking plate, to maintain the length of the lateral talar neck. Then we went on to the medial side. The medial side was also comminuted. In this case, I could not find a plate small enough to fit on the talar neck. So I used positional screws. These are 2.7 cortical screws, but the principle is not to compress the comminuted size, the side. So we have used plate on the lateral side and positional screws on the medial side. So here is another case where there was medial comminution, and you can see here we used a small cortical graft and a plate on the medial side to avoid a varus deformity. So one surgical tip that I can tell all the youngsters is you can put a K wire in the talar head and you can use this as a joystick. Now, if you want to reduce the frontal plane, you can toggle this joystick and reduce it into varus. Sometimes you also have malrotation. So again, that K wire in the talar head can be used to reduce the rotation also. So this is a Hawkins type 3 fracture. Now moving on from the 1s and the 2s to the Hawkins 3. This is not my case. This is from the AO archives, but just to show you the sequence of reduction. So in a Hawkins type 3, the body is going to be dislocated. The first step is to use a femoral distractor. You can also use a calcaneal pin traction. You want to distract the calcaneus, create space to bring in that talar body. And you can either use manual pressure or an elevator or even K wires to reposition the talar body. Once the talar body is in, you fix it like a talus, like a Hawkins type 2 fracture. So this is my own case. This 62-year-old male smoker comes in with a talar neck fracture. The body you can see is popping out. In fact, it had no soft tissue attachments. When we took him to the OR, did the debridement, the body popped out. So what is the 3D anatomy in this case? Again, very important to know. So as you can see here, the body is out of the talar mortis. The talus neck is very much in its position, but the body is out posteromedially. That is where the wound is, and that is from where you are going to fish it out and put it back. In addition, there is comminution of the medial part of the talar neck. So the wound was medial, extending to the sort of the lateral side, going from the medial to the posterior side. And in this case, we did a lateral approach first. You can see here, this is the talar dome. The undersurface of the body was comminuted, and there was actually the posterior facet, the part of the talus which articulates with the posterior facet of the calcaneus, was totally comminuted. So we decided to clean the body, put it in, and I used a temporary wire from the fibula to the talus to hold this temporary reduction. Now, mind you, the subtalar joint facet was completely, the posterior facet of talus was completely comminuted. So in this case, because he was a smoker, the subtalar joint would have been arthritic anyways. I decided to do a primary subtalar fusion. This also has the advantage of bringing in vascularity. Eventually, the person would have ended up in an arthrodesis anyways, but adding a fusion would possibly bring in a vascularity. That was my thought process. So I prepared the joint surfaces, put in 2 screws. This is a provisional wire which reduces the neck. The medial side was comminuted, and in this case, I used a medial plate to maintain the talar length and added a screw and a K wire on the lateral side. So this is 3 months follow-up. I don't know whether this you would say is a Hawkins sign or not, but luckily there is no sign of an avascular necrosis at the moment. It is still early days. I don't know how this case would do, but hopefully he should turn out well. The fact that he is a smoker makes this case even more challenging. So quickly running through the aftercare. So in our practice, we use a bivalved cast till suture is removed, and we allow them partial weight bearing. In a removable orthotic splint, we use an offloading and ankle foot orthosis. This is a pattern bottom ankle foot orthosis. and it takes care of your partial weight bearing. Full weight bearing is only allowed after there is full union and there is no signs of avascular necrosis. So the last part of the talk, what does the literature say? So the best outcomes in talar neck fractures are for those which have type 1 and type 2. Whenever you have complications, AVN, subtalar arthrosis, they result in poor outcomes. Now we all know this. As the degree of injury increases, the risk of avascular necrosis also increases. Hawkins sign we are all aware of, but just to revise for the youngsters. Now, even when you have an AVN, this is so important, not all AVN is bad. So Valier et al. Showed that revascularization in an AVN can happen in about 37% of the cases. This is a good number. So guys, when you see an AVN, all is not lost. You can put them on non-weight bearing or partial weight bearing mobilization, and some of them will vascularize over time. Even if there is a collapse, which is a partial collapse and does not involve the pillars, the patient may not do so badly. Other complications, subtalar arthrosis is the most common one. Malunion may happen if you do not stick to the principles of dual approaches and medial comminution. If you don't address that, non-union is rare and infection is common in 25% of open fractures. So the take-home points from this talk is that you need to do an accurate reduction for all the talus neck fractures. Do not commit by simply looking at an X-ray that this is a Hawkins type 1. Do get a CT scan. It may show you, displacement that you need to address. Use dual approaches. Preserve the deltoid blood supply. Avoid varus. All AVN is not poor, and subtalar arthrosis is something that you need to talk to the patients about. Thank you.
Wonderful presentation.
Thank you.
Always. And there were certain very beautiful points that you have made, and your cases were really marvelous. There probably is a question from Dr. Amina, sir. Yeah, please, sir.
Sir.
Siddharth, actually, question is a very well-known question. And as we are having a lot of medical facility in the rural area where the CT scan and the all means and ways for the fixation of these cases are not easily available. In that scenario, usually either they treat it either by conservative method or they refer to the higher centers. That take a time to come to a real expert like you or Rajiv or Santanu. So what I want to know is this, that what is the optimum time within that the fracture talus should be operated so that its percentile and the degree of AVN can be minimized or can be reduced. What is that optimum time?
Sir, that's a great question actually, and it is a very, very important point to highlight. So yes. If the talar body is not dislocated, if there is no subtalar dislocation, if it is just a fracture which has displacement, we can wait. There is no set time on how long we can wait, but possibly in those cases, the risk of AVN is not increased. This I have showed it in the study by Valier et al. Also and in another study. However, if you have subtalar dislocation, for the type 2B, or if you have a talar body extrusion, those are the cases that you need to reduce. A subtalar dislocation which you do not reduce would increase the risk of AVN. So at least a person in a rural setting can do a simple reduction maneuver and reduce the subtalar joint. If it does not get reduced, then the patient would need to be urgently referred to a higher center. Similarly, closed reduction of a type 3 talar body fracture, it can be tried along those lines. Now, mind you, sir, I have tried this and failed and then taken the patient to OR, but in a peripheral setting, at least they could try. If they are not able to reduce, then again, the patient would need to be referred urgently to a higher center, not only because of the risk of AVN, but because also there is a risk of pressure necrosis.
Certainly. Good.
Yeah. Rajiv, please go ahead.
I think it is not only the pressure necrosis over the screen, but if we look into the type 3 sort of fractures, talar fractures, the body normally go posteromedially. And then it is constantly pressing on the neurovascular structure.
Neurovascular, posteromedial neurovascular.
So it becomes very, difficult to decide at that. And I think if people learn a simple art of distraction with a femoral distractor, they may be able to put them back into position and keep the distractor there, keep the distractor out of the field where the future surgery is going. And if you can put it little back and send it, no matter, it may not be anatomically reduced, but if you can offload the neurovascular structure, that will be a wonderful job which can be done at the periphery.
Rural. Exactly.
That's a great point, Rajiv sir. I agree with you.
Yes.
Yeah, Rahul.
Yeah, so see, this point was so pertinent because talking specifically about this posterior medial body extrusion, I very recently, like 4 days back, had to amputate a patient who was sent back with the dislocation without reduction. So this point was so valid. Secondly, Dr. Siddharth, I just want your expert opinion about how to be sure that your fixation is not into dorsiflexion. Sometimes the talar neck fractures, they get fixed in some amount of dorsiflexion because of the dorsomedial comminution. So how do you assure about it that the fragment, that the talar body fragment is not into, the talar head fragment is not into the dorsiflexion?
Okay. So again, Rahul, that's a great question. Actually, that would be a master's level tip. But when you are putting in your screws, and if you look at the talar head from the lateral side, your screw should never be above the, the midpoint of the talar head. So if I'm sorry, I can't go back to my presentation now, but if you put your screws from a midpoint above that, from the midpoint of the talar head, that screw is going to bring your neck into dorsiflexion. So you always try to put your screw below the center of the talar head. And then you can also assess the inclination angle on the lateral radiograph. So it's a simple thing. You connect 3 points: center of the talar head, center of the talar dome, lateral process of the talus, and you can compare the inclination angle to the opposite side and ensure that there is no dorsiflexion malunion. But thank you for that great question.
Can I add something?
Yeah, please, sir.
There is one thing he said, that you have to be inferior to the central axis of the talus when you're putting these screws. So one tip to this is that it becomes difficult. You cannot. Okay. So you can make a small gutter in the dorsal aspect of the navicular. So through that you can, it becomes a little easy. So that is one trick I use when I want to put the screws in right position. So you can a small gutter so that your drill can go in that direction and the screw can also pass in that direction. So that is one tip I have for doing that.
But is that guttering doesn't produce any post-operative articular arthritis?
No, it is done on
navicular arthritis.
It is
like that.
done on the dorsum of the navicular, so that you can guide your drill and your screw problem. No, it has got nothing to do with the artery. So it is basically the dorsum of the, so that you can put your drilling machines or the drills a little inferior so that you remain in the end.
Okay.
So thank you so much, Dr. Siddharth.
Thank
Stay
you
with us so that we can have your comments and your points through the whole webinar. Now it is time for Dr. Rahul to come to the stage, to take center stage and present his talk on calcaneus.
Thank you so much, sir, for this wonderful opportunity to be talking on the calcaneum fracture in this mini IOACON. So we'll be talking specifically about the intra-articular fractures of the calcaneum, displaced intra-articular fractures. And I am actually trying to focus this talk more on the extensile lateral approach. See, we are just, as we were discussing, that a lot of our audience is the young guys who have just started fresh in their practice. So I guess for the calcaneum fractures, a thorough knowledge of the anatomy of the calcaneum and of the extensile lateral approach is a must before we start doing the percutaneous and MIS techniques. So we'll just start with a basic introduction that this is one of the most common tarsal bone fractures, with about 2% of all the fractures, and about 60 to 75% are the displaced intra-articular fractures. Now the idea of telling this this figure of 60 to 75% is that if we actually honestly see the amount of calcaneum fractures that are being operated, it is not up to this mark. So when I'm talking about 75% of the calcaneum fractures are displaced intra-articular fractures, so theoretically, we need to be operating on about 75% of the calcaneum fractures. So are we actually doing that? We know we are not. So that is the purpose of such meetings and such discussions, so that we can head in the direction of reaching this figure of operating on nearly all the displaced intra-articular fractures, wherever it is not contraindicated. And second important point is 90% is in young adult. So this comprises the important manpower, important earning members of the family who have to be back to their feet as soon as possible. So it is one of the largest bone of the foot and it functions as a lever arm for the strong gastrosoleus complex. And this is the basic anatomy where we know it has 6 distinct surfaces. The superior surface has calcaneum tuberosity to be the extra-articular, and 3 articular facets of anterior, medial, and posterior surfaces. Then we have anterior surface, which is saddle-shaped. The lateral surface has peroneal tubercle and groove, which becomes a source of pain mostly after a conservatively treated calcaneum fracture, which was displaced because of the lateral wall blowout. We have a medial surface, which is stronger, and sustentaculum tali, which is the stable fragment of a fracture, which guides us mostly towards a fixation, is a part of the medial surface. And then finally, we have inferior surface of the calcaneum and the heel pad. So these are the various parts of the calcaneum as a whole. So the mechanism of injury is mostly a high energy trauma, a fall from height, RTAs, and fracture pattern depends on the position of the foot, the extent of force at the impact, and the quality of the bone. So talking about the primary fracture line, mostly it passes laterally because of the subtalar joint eversion. The lateral process of the talus, it gets impacted, divides the lateral wall and the body of the calcaneus into 2 fragments, which is one is the medial fragment or a sustentaculum, and then there is anterolateral fragment. And then comes, if the force continues, the secondary fracture line, which might cause a posterior depression or inferior tongue depression, depending on the direction of the force. So these are the basic theoretical points. Now coming up to the stepwise management of a patient who has, who has come to us in an emergency. So we have to do a thorough clinical evaluation. As we were talking, it might be associated with a severe disruption of the soft tissues, may have a compartment syndrome, look for the skin blisters, any open injuries, any other associated injuries, because these are mostly high velocity trauma. So you could be with such type of pictures. The patients might have severe swelling. This is a bilateral calcaneum fracture with fall from height. So this is a strict no-no condition to be touching this patient. We have to wait for the skin condition to improve. And meanwhile, we'll go ahead with the radiological evaluation of this patient, which includes important X-ray views and CT scan of the patient. So the plain radiographs, it has to involve foot and ankle. It has to involve the view of the hind foot, AP view of the foot, axial view of the heel, mortise view of the ankle, also the spine and pelvis as a part of the trauma survey. And we have to look at the crucial angle of Giessen and the tuber-Bowler angle in both the views. So when we are looking at the lateral view, we have to look for the intra-articular extension of the fracture pattern, joint depression of the tongue type of fracture, the loss of height, decrease in the angle of bolus, increase in the angle of Giessen, or a double density sign when only a lateral portion of the posterior facet is involved. Similarly, in Harris axial view, we look for the calcaneum height, width, varus angulation of the heel, and the articular surface. So these are the lateral and the axial views where we have to look for the articular fragment depression. We have to look for the heel where exactly it is, the articular surface. Then we have to look at the AP view and the mortise view, look for the CC joint, anterolateral fragment to guide us towards the fixation, lateral wall, posterior facet, and any abutment. So these are all the clinical X-ray views that you need to have while we are evaluating a calcaneum fracture, especially the intra-articular calcaneum fractures. This is a double density sign. Usually when only a lateral half of the facet is involved, we see this. And finally, the Broden's view. This is an intraoperative view for basic of the adequate reduction of the calcaneum fracture. CT scan, ideally you should have a less than 2 millimeter interval cuts. We have to take axial, sagittal, and 30 degrees semi-coronal cuts. So in a CT scan, we can look where exactly the tendons are, how the lateral wall is butting over the tendon, where is the superior lateral fragment. how is the situation of the posterior facet, calcaneocubital joint. And then on the basis of this coronal plane, we can look for the Sanders classification. So just a few examples of all the type of Sanders. This is Sanders type 1. This is Sanders type 2, depending on the fracture line passing through the posterior facet. This is Sanders type 3 and type 4 classification. Coming up to the management, now that's the important part, and various approaches can be used depending on what management principle and fixation method are we using. It could be a medial, a lateral, a combined approach, an extensile approach, which is one of the most common for the operative calcaneum. Sinus tarsi, minimal invasive approach, which is fast becoming one of the most commonly used, especially with the foot and ankle surgeons, a percutaneous fixation, or a primary arthrodesis. Sometimes in the Sanders type 4, you might go for this. Always and always wait for the wrinkle sign to appear before you try and touch the patient. All the preoperative radiographs as we had seen before. So now we'll discuss a couple of cases. So this is one of the case where we could see the articular fragment, the lateral wall, which is blowout. And we had done an extensile lateral approach. We identified the articular facet, elevated the joint. This is one of the other cases, corrected the heel varus, elevated the articular surface, and finally a plate fixation was done. Similarly, one more case. Now you could see a double density sign where we know that there is a lateral wall of the facet involvement, and we have to lift it back to its normal position and then attach it to the rest of the fragment. So this is how it looks like when you open from the extensile approach. This is the posterior facet of the calcaneum that we are seeing here. This is the lateral wall. Now we can elevate it up again and fix it there. So these are just few of the examples. Now you see we have reduced the fragment back to its normal position. We have corrected the angles, temporary fixation, and then we did a final definitive fixation. This is one more important case where you could see the lateral wall blowout. The articular fragment is here, which has to be elevated back. And we went ahead with the sinus tarsi approach for the same patient. This is how this incision was done to compress the lateral wall blowout also. And then we reduce it with now this is interesting. This is one of my favorite implants now for the sinus tarsi approach, this plate, distal radius plate, which is a wonderful implant for this. And this is one more sinus tarsi approach with the lateral wall, lateral facet involvement. And here we have used a standard sinus tarsi plate, the Arthrex sinus tarsi MIS plate that has been used to reduce back the articular segment. So now I'll focus a bit on the extensile approach. These were all just the examples, but I want to focus on the extensile approach as to how to go ahead with this, how to approach, what are the basic points. So the step 1 is the patient positioning. Then we mark the important landmarks. We do incision, we raise the proper flap, retraction and joint exposure, lateral wall exhaustectomy, identification of a depressed fracture fragment, elevate that fracture fragment back to its normal position, fix it, see the plate position under the C-arm, look for the adequate reduction with the help of the Broaden's view, and then do the closure. So we'll just have a small video and we'll go through all of these points one by one. So this is how we start. I'll start with extending the limb. So once that has been done, we go ahead with the marking. So we achieve the marking, we mark the CC joint, the lateral malleolus. Then the incision is more towards the tendo Achilles. And once we have done that, so this is the final marking for me. Then I will take my knife. I usually use a 15 blade and do elevation of the flap. Now we have to make sure that the flap is thick. There is no undermining of the skin. So this is how we raise the flap. Now this has to be thickness of the flap. Right bone deep you have to go. So once you're bone deep, make sure you do not use your sharp instruments over the skin. I mean, here trying to just hold it with a toothless, this forceps. The forceps is a toothless forceps that I'm trying to hold. And once you have done that, make a thick flap, raise a thick very thick flap. That is the most important point while we are raising the flaps. So once we have raised the flap, what I do is I use a small periosteum elevator just to know the extent where I have to go. This helps me also. This goes under the tendon, helps me with identification of the capsule and other structures so that I can easily clear that off. So now, once I have used this periosteal elevator, I'm opening up the posterior facet. So now you can see the posterior facet clearly here. And this helps a lot into this exposure. So once we have done this, this is the posterior facet. I try to hang the foot of my patient over this boulder. And then comes the next part, whereas we retract the flap. So I use KYS 1 in the fibula, second goes into the talus, the third into the cuboid for the retraction. So yeah, this is a third wire that I'm putting in the cuboid for the purpose of flap retraction. So this completes the retraction and exposure. And now we can clearly see the posterior facet, lateral wall, everything is visible here. And now I'm going ahead with the lateral wall exhaustectomy. I'll remove this lateral wall to identify further, to look for the depressed fracture fragment. Okay, so once we have removed the lateral wall, now this is the depressed fragment which we can see, and we'll try to elevate with the help of the, so this is where we have elevated the fragment with the help of our periosteum or the osteotome, whichever is your choice. You can use your curved artery forceps also for the same purpose. And then we do a temporary fixation at this point. So once we have done a temporary fixation, now I am trying to fix the lateral wall, the partial part of the posterior facet to the remaining facet with the cancellous screw, compression screws. And once I'll confirm under the CM, once I'm doing that. So yeah, so now we have finished. Now we have put back the lateral wall over the original position. Check under the CM whether it's fine or not. Put the plate at the right position and then do a definitive fixation with the holding screws. Now, the number of screws is just has to be a holding screw. I use mostly the locking plates. Very rarely you need to have a compressive screw through the plate, because once you have already achieved compression through the interfragmentary screw underneath the plate, you just need a neutralization plate to be put on finally. So this is where we close it. And finally, we will check after putting the plate, what is the status. So this is the next screw that we'll put in. So once we have achieved a stable fixation through all the screws, then we proceed ahead and look for the joint surface through the intra-articular Broaden's view. You have to see at all the angles to make sure that there is no step in the articular surface. This Broaden's view has to be seen preoperatively also. So yeah, so this is the final plate fixation. And now we'll go ahead and try to look at the Broaden's view in different position, 10 degree, 20, 30, and 40 degree of angle. So this is a nicely fixed articular surface. And then we'll finish with the closure. The flap closure, again, is very important. It has to be closed without the use of any sharp instrument, minimal hard instruments on the skin. I try to put in a few subcutaneous before I do a final fixation with the Algover Donati suturing. So that is my way of fixing the tensionless suturing with Algover Donati. Minimum number of stitches. See this, finally you have a complete closure with a good overall articular surface of the calcaneum. So then you can have a good post-operatively walking patient, a patient which is fine, happy after 6 months of the surgery. And just one article I would like to quote is the epidemiology and trends in the surgical management of the calcaneum fractures, which was given in the Bone and Joint Journal. And the purpose of this surgery was to find out about the rise in the calcaneum fracture surgery after the invent of a better technique and the MIS surgeries. And there was a significant number of rise over the years, over the last 20 years, in the number of the intra-articular calcaneum that have been, which were previously being managed conservatively and have significantly increased to be managed operatively now with the advent of newer techniques. So this is what was my point, that more and more number of the calcaneum fractures, which is intra-articular, which is depressed, is in young patient, and it has to be operated for the best possible outcome for this patient. Thank you.
Yeah, thank you so much, Rahul. And how nicely you have walked us through the extensile lateral approach. So let me first invite question from the learned faculty, and then there are certain comments and questions that I myself will put forward to you. So is there any, Rajiv Vora, sir? I need to unmute yourself, sir. Unmute yourself. Yeah. No, unmute yourself, sir.
Yeah. Can you hear me?
Yes.
Yeah, now.
Yeah. The only thing which I want to say is that we are looking more into limited incision approaches and everything day by day, but we should know which fracture we can actually fix through these sinus tarsi approaches or a limited sinus tarsi approach. We need to understand this. Just don't get carried away. And if you do your lateral extensile approach properly, the incidence of wound adhesions, which has been quoted in literature up to 30% or something like that, is, I think, in my cases, I must have done around about 60, 70 cases. And I have just seen one case where I could, see the wound. So if you handle your flaps, don't get scary from the literature that extensile approach is a bad approach, and keep your approach selection according to your expertise. And you should understand, you must have done extensile lateral approach before going into the limited approach. Otherwise, you will never understand what is going on. So don't get, that is all I have to say. That is all I have to say.
I have a question, Rahul.
Sure, sir.
Can you tell me how you get in the sustentacular screw, the screw from the lateral side right into the sustentaculum to support it? Because that's a very tricky screw to get in. So do you have any tricks to...
Yes, sir. So my idea, the most important part is I put that screw mostly under the vision of C-arm in axial view. That's it. That is the first thing that I do. I never try to put that screw first, put it, then turn the C-arm into axial and try to see whether I have achieved or not. So once I try to do it, and always before putting this, I make sure that I've stabilized my the facet nicely with a couple of KY so that it doesn't move. And what I've seen is, if I start right at the midpoint of the posterior facet, direct your screw slightly inferiorly and slightly distally. It is going direct exactly into the sustentaculum tali. Nowhere else it is going to go.
Okay, good. Thank you.
Sorry, he said inferiorly. I think it is to be directed a little anteriorly and upwards, if I am not wrong.
So I take it right below the articular cartilage. My entry point is right below the articular cartilage.
Okay.
Rahul, a question for you.
Yes, sir.
Suppose you have comminuted the posterior facet. Do you always put in the screw? Because sometimes you have the thing just splits open when you try and how do you bail out of that?
So what I believe is, it depends a lot on the size of the facet. And sometimes the facet is so small that you just cannot put a screw. So in that particular position, what you can do is what I have done a couple of times is use the plate as a buttress, just to keep that part of facet over there. Don't try to put any screw into it. Use the plate as a buttress. You just put a compression screw through the plate itself, which will hold it and keep it there.
Yeah, Dr.
How many times did you should have put a graft?
I never did.
Okay.
I never did.
Dr. Siddharth.
Sir, but that interesting question on the comminution of the facet. So if the CT were to show that this is a Sanders 4, and anyways we are going in to operate for reduction of the varus. It's not just the posterior facet, but they also have a gross extra-articular deformity. Then I would not worry too much about the the comminution of the facet and just try to get as good a reduction as Rahul has already said. For the Sanders type 3, it sometimes helps to fish out those fragments. So you can get two large chunks of the articular surface out on the table, reduce them under vision, hold them with a small K-wire. At that point, if you just retract the tuberosity backwards with a hook, you can see the sustentacular fragment. So then under direct vision, getting the tuberosity out of the way, you put it back, drive that K-wire in, and use a screw, or if the facet is too small, sometimes use a buried K-wire to that effect.
Yes.
Rahul,
So something like a misses wire technique, something like that.
Yes.
Yeah, Rajiv Vora, sir.
I personally don't use much of graphs, but there's one situation where I don't mind it. When you get those fragments out, most of the time you see quite a lot of cancellous bone is attached to them. So they are not flakes. They are quite so in those cases it is not. But sometimes they are so thin, and it is very difficult to even raft them. What Rahul meant, it's a raft screw you want to use under that. So in those cases, I don't mind putting some graft. Particularly, I don't want a graft from here. I use just an artificial graft, a cube or something like that, because that there is nothing in loss which can keep it there. But most of the time, the fragments are this that you can raft them. But when you cannot raft them and you think you can collapse, in Sanders 4, what Siddharth was saying, that most of the time you're expecting an arthritis on the late stages. So if the collapse occur, it doesn't. But sometimes you don't have that much of combination, but the fragment, the bone left with that flake is very less. In those very rare cases, I don't mind putting that graft. That is
So just to add to what Dr. Rajiv has said, the lateral wall is also a very good source of graft. So unless I wanted to, really you can always use that as a graft and really not worry about it. That is a good source of graft material.
Absolutely. Any more questions from the learned faculty? Well, I have one, but before that, I think it was a wonderful presentation that you made, and the comment made by you as well as supported by Rajiv Vora sir, that miss for the purpose of miss should never be done. Miss for the purpose of fashion should not be done. It is very important that the beginners, the learners, the initial surgeons should practice the extensile lateral approach as much as possible, because after all, calcaneus is an odd shaped bone. So need to understand, orient yourself. It is good to have a good practice of extensile lateral approach, number one. Number two, it is very important that you have your position of C-arm properly, which is all the more important while you're putting the screw in the constant fragment. Let me tell you what I do. You also often use the pedicular screw probe and use it just before I put the screw. I just put the probe and feel all around whether I am putting the screw in the bone, in the constant fragment or not. That is one way which I do. Now, one very important question is, see, there's one thing to get your reduction right of circular congruity. And the second point is that you get the height, width, as well as length of the calcaneus right. So there are two factors and both are desirable. So which, in your view, is the factor number one? Which is more important, to get the height, length, or width perfectly, or to get the subtalar congruity perfectly? Which one would you value more?
I would value the subtalar congruency of the joint to be the number one. My idea is the first thing that is going to trouble the patient is the pain. It's going to be the posterior subtalar joint pain. And eventually, if you don't get your alignment correct, if the heel is still in varus, eventually he will end up there. So overall, if you see, you have to correct all the possible parameters before you are out of the OT. But for me, the first and foremost is the subtalar joint, followed by the heel. The varus has to be corrected, and lateral wall blowout has to be corrected. These three, if you have managed, rarely patient is going to complain of any other thing majorly.
Your view on this question, Dr. Siddharth, and yeah.
Sir, I would approach the problem in an entirely different way. So if I can get the height of the calcaneus right, if I can correct all the varus, and if the anterior end is comminuted, hopefully get the lateral column length right, then subtalar arthrosis, to my mind, is a very small problem. Either the patient may not complain of it at all, or I'm just looking at a straightforward subtalar fusion. So in bad cases like these, I always look at the extra articular parameters. And of course, when you are so much involved in it, the facet will either fall back into place or it will be too bad for you to do anything. So I would tackle the problem from the other way.
Yes, right. Because this is what I also feel. Because this is a question which have been asked multiple times, and I feel that the pain generators, they mostly come if the height, width, and length is not proper. That's why you get more of the pain generators. So it is more important. It is very important for me to get the articular surface right, but it is more important for me to get the height, width, and length right.
Sir, so an analogy I give to my friends is if you had a tibial plateau fracture with only arthrosis, and you had a tibial plateau fracture with gross varus and deformity and arthrosis. So the one with gross varus and arthrosis is, of course, the bad one.
Yes.
That's what I'm saying. I guess this question has multiple parts.
Yes.
So it depends on what kind of fracture pattern we are looking at, what classification we are looking at, and then we can decide what parameters we are looking at.
Right. Yeah, Rajiv, sir.
I think the key to congruency of the subtalar joint is restoration of the height, length, and width.
Absolutely.
So this is the key. Then why not use the key and just rely on what we want to get? So I agree with Siddharth that if this is the key, why not use it? If you don't use it, you will never get the subtalar. So please keep in mind. Of course, the final aim is getting the subtalar joint, but you will never get it if you don't use this key.
That's exactly what I'm saying. So eventually, it has to be there. So somehow, however you achieve, you have to reach there by correcting all the parameters.
So have to do it.
And in those cases when there is a lot of combination, and probably you're not able to get the articular surface correct, then maybe you have to concentrate on getting the height, width,
and the alignment. Yes, absolutely.
Thank you. So thank you, Dr. Rahul. That was really a wonderful masterclass on extensile lateral approach. Your video was wonderful. Thank you so much. Be with us. And may I now invite our President-elect, Dr. Malhar Dave, sir, to present his talk on navicular and cuboid.
My screen is visible?
Yes, it is.
Okay, fine. Okay, good evening. I'll be talking on cuboid and navicular fractures, one of the less talked about injuries, but more so important. Cuboid injuries are and navicular are either missed or inadequate diagnosed in many percentage, about 30 to 40%. And one of the primary factors would be low incidence of occurrence. And they present in various forms. So people tend to sort of miss those. And they also are associated with concomitant injuries. There are subtle radiological signs for these fractures, and they also have some component of ligamentous injuries along with them. One of the mechanism of injury is compression on one side, and you should take both the navicular and the cuboid as one single entity, and then you will be able to look for the other, even though when your mind knows that there can be an injury on the other side, on the on the contralateral side also. So 50% of patients will have 2 or more bony components. So that has to be kept in mind. You cannot, usually the isolated nutcracker fractures are rare. And one of the key signs that there would be an injury is a plantar ecchymosis, wherein there is a rupture of the plantar ligament. Zwift described many patterns of these both bone injuries, either going from the transnavicular, transligamentous, or transtalar. On the lateral side, the transcuboid, again the transcalcaneum and the transligamentous. So you can have these mixed injury patterns for the cuboid and the navicular. Now, what is the role of the cuboid bone? The cuboid articulates with the 4th and 5th metatarsal base, and it causes maximum dorsiflexion and plantarflexion of the midfoot. And during the pronation and supination, the calcaneocuboid and the 4th, 5th metatarsal cuboid joint participates. And so when you have a loss of lateral column length, you will have a forefoot abduction, planus and hindfoot eversion. Now, cuboid injuries, cuboid bone is usually a non-articular on the dorsal, lateral, and the plantar aspect, and the most important ligament is the plantar ligament. The lateral plantar artery and the anastomosis around it provides good vascularity. So the non-union and the avascular necrosis of cuboid is unreported. The fracture patterns in cuboid can either be an avulsion, twisting injury, which can be small and they are more likely to be missed, or you can have a crush injury, which can be a high energy articular involvement similar to a nutcracker fracture. So this is the OTA classification which is readily available. They have described into ABC as they do it in all patterns. So when you are evaluating this injury, you have to take in comparison contra X-ray of the another foot. You might need a CT scan, and the medial oblique view would help you delineate the fracture better. The stable injuries, stable ligamentous injuries, small bony avulsions, and undisplaced fracture can be treated conservatively in a plaster, whereas fixation would be required for those fractures which are significant shortening, have an articular step, and though much literature is not available on the cuboid fixation, these are the photos from the AO website. You start the incision as we take the sinus tarsi approach from the tip of the fibula to the 4th metatarsal, and you have to take care of the sural nerve. And then you can distract that joint and use K-wires or bridging plate, bone graft, depends on the fracture pattern. There's a very nice paper on cuboid fracture on the JBJS, and wherein they describe both the cuboid and the navicular fractures. So this is, and wherein they gave the treatment guidelines. So this is the avulsion type, wherein you usually treat it with non-op. The extra-articular axial load, again, it is treated non-operatively. The intra-articular axial load, wherein you might need to do an open reduction and bone grafting if there is an articular depression. So that in that case, you might need to do that. When the tarsal metatarsal joints are involved, you have to treat internal fixation for the metatarsal joints, and you might need to fix the cuboid also. And when there's significant combination, you will have to do a length via an external fixator. And when there's a bicolumnar, it depends on what type of pattern you have. This is an X-ray similar, shows a comminuted navicular and a comminuted cuboid. And maybe you will have to do an X-fix on both sides of the foot, on the medial and lateral. So this is just in case example as we are taking the classification. So this is a comminuted cuboid. There was no significant navicular injury. If you can, this is the CM image as we started the case. Significant combination in the cuboid. Took a small sort of an instrument to dental pick sort of an instrument to guide those small fragments into place, and then put in an X-fix and then tease those fragments into their places, and then pass in a K-wire, and then after 8 weeks, remove the fixator and the K-wire with a significant restoration of the length of the cuboid. Another example, another thing is of the navicular fractures. navicular fractures, because I think I think I missed the slide. There's another cuboid case, shows a combination of the cuboid on the X-ray, the navicular, I think again intact. We did a CT scan which shows combination of the cuboid, significant on the plantar aspect. These are the coronal and axial images, and then did an open reduction and internal fixation with a mini mandibular plate with screws, and to restore the length and the articular congruity of the cuboid bone. Okay, talking about the navicular fractures, they are usually either the dorsal lip avulsions. They are more common, about 50% of the cases, and these are due to the avulsions of the talonavicular ligament. And these are usually minimally displaced. If it is large, you might need to fix it. Otherwise, it is treated conservatively in a plaster. The navicular tuberosity, you can have an acute eversion injury, and then it has the tension on the posterior tib tendon. If it is displaced and articular involvement, you need to fix it. If it is not, you can treat it conservatively in a plaster. Sangosan described displacement greater than 5 mm to be fixed, something like a medial approach. The non-union of these fractures are usually asymptomatic, but if they are symptomatic and large, you can fix it with a bone graft. If they are small, you can excise it. Again, navicular fractures are also divided into the body fractures, and they are usually because of high energy trauma and are associated with talonavicular subluxation. Many times they present late, and in some cases you might even have to do a fusion for those sort of cases. CT scan helps in preoperative planning, and there are set patterns of injuries in this. You can have coronal, dorsoplantar, and a comminuted one. So as I told, you need to stabilize or you need to fuse when there is significant combination, and if possible, try to avoid the talonavicular fusion. But sometimes we have to do it in case they present late. So again, from the AO manual, the navicular fixation, this is the dorsal medial approach. You can cheat towards the medial to the tibialis anterior to have access around the tuberosity. And then you will have to take care of the intermediate dorsal cutaneous nerve. The central navicular is access between the tibialis anterior and the EHL, whereas the lateral part between the EHL and the EDL. And you should use a distractor frame medially. The plantar fragment is usually constant, and you should start a reduction from lateral to medial. You might need bone graft. You can take it from medial malleus. Don't strip the periosteum, because that is a good supply to the navicular bone. You have to do sort of an open book sort of a reduction, flip that small periosteal sleeve open, and then you'll be able to reduce. Okay, so this is a case example, a comminuted navicular fracture along with tuberosity fracture. And then it was opened by the dorsomedial approach. It was fixed with a screw, and then didn't have the plate. I was doing at somebody else's place, and then put in a medial distractor frame to hold the reduction. Again, another comminuted navicular fracture with significant displacement of fragments. This is the other oblique view, and then used a plate to fix those fragments, but there is a minor step. If you can see it in the central part, if you're able to see the central part, it's a plate. There's minor step at the reduction. Similar third case for a navicular fixation looks quite benign, but when you take the obliques view, you have significant combination over there. The step in the articular cartilage, and we did the CT scan, which showed significant plantar combination in this case instead of dorsal. Plantar and the lateral combination. I fixed it with a K-wire screw and a plate. Tried to get everything lined up. Looks quite okay on that part. Another case, this was a simple sort of a two-part navicular fracture, fixed it with Herbert screws, but it went in for a late collapse. And if you can have a look at a talonavicular arthritis getting developed over the joint at the period of 3 years. So this is this is a potential problem with these sort of injuries. Another case with significant comminuted navicular fractures, again, used plate, mini plate and screws, and shows reasonably good alignment. The prognosis with adequate reduction, most will have good results, but very few are normal. Type 3 have the worst prognosis, and they can develop osteonecrosis with collapse. Stress fractures are uncommon and usually due to repetitive stress. And as you can have vague arc pain and medial tenderness. You should do an MRI. Navicular stress is usually you give a non-weight bearing cast, and then if it has a non-union, then you can bone graft and fix it. Thank you.
Yeah, hello, sir. That was a very nice presentation, of course, on a subject which is not very often touched, but these are very important bones. So my question is, how often do you resort to conservative treatment for an undisplaced fracture?
So for undisplayed, it is mostly conservative only. Now, these are not all cases at my place. So I get a call to operate at other places. So there's a pooling of these fractures. But mainly the commonest presentation is the avulsion type of navicular fractures. And the undisplaced cuboid, which we commonly see. These are uncommon injuries which are present.
Right. Any question from our learned faculty? Dr. Siddharth?
No, sir. I think it was a great talk, and of course, our president, sir, has covered all the points in very great detail. Excellent presentation, sir.
Thank you.
Thank you so much. So I think if there are none, then I can move forward and make my own presentation. Just give me a moment. Is my presentation visible to all? Hello?
Yes, sir, it is visible, sir.
Right. Thank you so much. So now moving on to the second last presentation of our webinar, I shall be talking about Lisfranc injury, diagnosis and treatment. These are a very important injury in the sense that they are often missed. And the layout of my talk is introduction, diagnosis and treatment, of course. So Lisfranc injuries are the injuries of the tarsal-metatarsal joint where any of the metatarsal is displaced in relation to the tarsal bones. And the most common one to happen is of course, the first metatarsal. Sometimes it can be second metatarsal as well. This has a wide spectrum of injury. This could be something very innocuous with low injury, just the ligamentous injury, to something as grotesque as we can see in the screen, which is because of a high energy direct injury, resulting into fracture dislocation. Low energy injuries are often misdiagnosed as sprained and are treated inadequately, thereby leading to problems later on. And whereas errors in fixation of high energy injuries sometimes entail unavoidable complications. So the principles are to be taken care of properly. As we all know, the Lisfranc joint is formed by the 5 metatarsals articulating with the 3 cuneiform and the cuboid one. Trapezoid shape of the base of the medial 3 metatarsals, along with their corresponding cuneiforms, forms the transverse arch of the foot, which is akin to the Roman arch, where the second TMT works as a keystone. That's why the second tarsal-metatarsal joint is very important. There is a schematic diagram on the right side of the screen, which shows the very important Lisfranc ligament. which along with the dorsal and plantar tarsometatarsal ligament maintain this particular arch. Now, for diagnosis, we of course have to take history, clinical examination, investigation. High index of suspicion is what will help us in diagnosing the treatment, especially the low injury treatment, low energy injuries, which are generally due to axial lowering of the hyperplantar foot. Sometimes the injury can be of high energy, and then we have an open kind of injury. And in those high energy cases, we have to watch out for the compartment syndrome. In clinical examination, the telltale sign, of course, is the plantar ecchymosis, which we can see in the picture. There could be swelling of the midfoot or at the midfoot forefoot junction. In clinical examination, we have to look for the tenderness. We have to elicit the piano key test. There could be a positive palpable gap between hallux and the second ray if there's a lot of displacement. And sometimes, because of the involvement of the terminal branch of the deep peroneal nerve, there could be altered sensitivity if the injury of the long duration. So the ecchymosis can be even very minimal as in this case, but we don't have to miss that. Then in diagnosis, standard AP lateral and oblique view, and the stress view and the weight bearing view. Sometimes the injuries are very common, as very clear in the X-ray, as we can see here. And these are the radiological criteria. I expect all my young friends to be aware of these ones. I'm not going to read all of them, but we know how to see them. We have to see the alignment of the bones and also have to be very careful in looking up for the bony flex sign, which are present here, for example. And in the other views, we have to take the weight-bearing view. And in weight-bearing view, sometimes we'll have a displacement which is not there in this case, but sometimes there could be displacement like this. And then the other modalities of diagnosis is, of course, CT scan, 2D and 3D CT scan. 3D CT scan is, and 2D CT scan is, of course, more important when there are comminuted bony injuries, as we can see in this case. MRI is helpful in purely ligamentous injury or injuries which are of long duration. Then the management and treatment, we have to be clearly understanding the 3-column concept, the classification, the treatment algorithm. I'll also be talking about the controversies, case example, and complication. So as we all know, the medial column and the middle column, they are more stable ones, and the lateral column, they are mobile ones. So the medial column, which carries most of the load while standing, and the middle column, which is the least mobile, are to be looked very carefully whether there is injury or not, and if there is injury, their stability and their integrity is to be restored. This is the classification. I'm not going into the detailed ones. And this is Nulle's Vertellus classification for purely the ligamentous injury. Treatment. The goal of the treatment is to restore the anatomy of the midfoot, hence its function, preventing later arthritis and disability. Non-operative treatment has very, very limited role, as significantly lower functional and radiographic outcome noted with non-operative management of displaced unstable injuries. But non-operative injury does have a role in very limited subject. These are the ones where the injury is non-displaced and they are stable. When the patients are not fit for surgery, like these ones. And this is the treatment algorithm. The Lisfranc injury, whether it is stable or unstable, that is to be clinically found out. And if there is, the injury is stable, there is no instability. And we can see that also, confirm that also in the weight bearing and stress X-ray, then we can go on and do a non-surgical treatment. However, in most of the cases, if it is unstable, then of course we have to fix If it is purely a bone injury, or if it is a ligamentous injury, then we have to do arthrodesis. But if the injury is very bad, high energy, then we may have to temporize, and we may also have to do fasciotomy later on. When these factors are taken care of, we can do the internal fixation. Now, few points. In those cases which are of high energy, we need to do a temporary pinning and delayed open reduction internal fixation. When the soft tissue swelling is very marked, then we can do X-fix fixation, which will allow the axial restoration, alignment restoration, and will cut down the risk of compartment syndrome. And definitive surgical treatment can thereafter be taken after, let's say, 10 or 15 days when the wrinkle sign appears. And open reduction and internal fixation is mainly for bone injuries. We have to rigidly fix the first, second, and third TMT joint. And K-wire fixation is just for the fourth and the fifth joint. Reduction is always medial to lateral, and we have to plan according to the case. There are certain cases, there are certain surgeons who just say one incision is enough, one incision versus double incision, but in most of the cases, we use double incision. And whether we use a screw or plate, we'll see later on. The third one, that is whether to do primary arthrodesis or to do bony fixation. Primary arthrodesis is mainly for the cases when the injury is purely ligamentous, and if the patient has come to us after a long time, and if the deformity is chronic. Now, for surgical treatment, where do we do osteosynthesis of primary arthrodesis? I have taken care of that. Osteosynthesis is mainly for the bony lesion, where primary arthrodesis is for ligamentous injury. Now, whether to have a transarticular screw or dorsal bridge plate. Dorsal bridge plates are the new ones which have come recently. And since these are articular injuries, some people do not advocate the use of screws. Rather, we have to go on to the plate. The rational approach is use plate for comminuted fractures or for cuneiform or metatarsal bone. And when the combination is not much, we can go on with the screw fixation. Single or dual incision. The classical approach, of course, is the dual incision. The first one is in the first intermetatarsal space, and the second one is over the fourth metatarsal. But sometimes, if the size of foot is very small, the skin bridge can be very narrow, and then it will cause soft tissue issues. Hence, some worker advocate single large incision over second metatarsal, because then you can go this way and that way and take care of all the injuries. There are some examples, pre-op, post-op, where all the medial 3 columns have been fixed rigidly. The lateral 2 columns are fixed with K-wires. But the associated injury like cuboid injury, that also needs to be taken care of. Direction of the screw. Now the latest is to have a retrograde screw where the screw head is into the base of the second metatarsal, because the thread purchase is more in the first cuneiform. These are the complications, which could be post-traumatic arthritis. Then we have to do, of course, arthrodesis. In all cases, again, we have to go on to do the arthrodesis, and we have to take care of deep infection if this occurs. So the take-home message is that timely and correct diagnosis is of paramount importance. We have to devise a correct treatment strategy for that particular case. If we are attempting osteosynthesis, anatomical reduction and correct method of fixation is to be taken care of. If attempting arthrodesis, ensure union at the arthrodesis site. Communicate well with the patient so that he understands that these are tough injuries to take care of, and you can treat them. You can make them understand any possible complication for which they need to come back and get treated. Thank you so much. Stop sharing. Right.
Am I visible?
Yes, sir, you are.
Okay, so after a big session for trauma, and that's what we are known for, orthopedic surgeons. Unfortunately, if you send your own kids to be brought up in the hostile environment, you have no direct vision over them, and what turns out to be, you don't know. It's the same thing with the diabetic foot. Diabetic foot has always been given to the general surgeon, to a person who knows nothing about the orthopedic biomechanics. He has no clue about what the foot structure is, and he keeps on biting and tearing through the tissues of those necrosis, and then finally the ulcer never heals, and then finally this infection gets into the patient's system. It's a dysvascular limb and lands up with the amputation. So amputation for us of the diabetic foot is failure of healthcare in its base, and that's why I thought that it should be my theme as a president, to save the diabetic foot. Though it may be a little boring and not as exciting as the trauma that we all do, but it is very pertinent to understand that we need to get back into this region and do our best to these patients so that we reduce the amputation rates, and that would be a big success. So greetings from Goa, from where I come from. This is my hospital, and that's the beach side, and you're all welcome anytime. The first thing that I would like to advise all my orthopedic colleagues is, do not treat diabetic foot alone. We have to be comprehensive, it has to be integrated. Involve the general surgeon, because we need them sometimes. Of course, we are there, then the physician for a good glycemic control, the microbiologist for infection management. Vascular surgeon is an extremely important part of the team, especially in those diabetic foot ulcers which are dysvascular, which is 25% of the problem. Sometimes we require the plastic surgeon for achieving a cover. And the most important guy is the orthotist. So if you ask me one important person in management of a diabetic foot ulcer, other than the orthopedic surgeon, is the orthotist. Of course, to make our job easy on a day-to-day basis, we need to have a wound care nurse who also can be doubled up as a counselor. Because in treatment of diabetic foot, education is the most important thing. So what's the spectrum of orthopedic care? We would be coming in a situation where the patient may present to you with a diabetic foot ulcer straight away, a non-ulcer on the foot, which you know is a very, very easy way to make a diagnosis. Sometimes these ulcers are infected and they come with draining pus or a small discharging sinus. They also present with foot and toe deformities, because by the time the neuropathy has acted on the foot, you get something called as the intrinsic minus foot, which is where there are abnormal pressures on the foot. So you have multiple toe deformities like claw toes, you have the hallux valgus, you have sometimes the midfoot collapse, like in the typical Charcot's. You can also present with an acute or a chronic Charcot, which we should be able to identify and differentiate from an infection. And our main aim, the way we can deal with the wound, that is something that we have to be a little bit more aggressive. And again, as I said, the key here is providing an offloading orthotic as early as possible. So we have to stratify this at risk patients. Who are the patients who are at risk? One, those who have neuropathy, which is the most common reason for a diabetic foot ulcer. Then people who have developed deformity as a result of the motor neuropathy. Patients with a peripheral arterial disease who have a critical limb ischemia, poor glycemic control. And the important thing, before even the ulcer occurs, to identify the pre-ulcer lesions like the corns, the callosities, the cracked skin, infected nail beds. This is something that we have to pick up early, and this is where the wound care nurse comes into the picture. Any history of previous ulcer and amputation increases the risk 5 times. Long-standing diabetes, ill-fitting shoes. Make it a point to inspect the shoes of every diabetic patient. And we need to also address their chronic renal problems and abdominal lipid profiles, because that would affect the outcome of the treatment. So as I said, the common foot deformities that we see is hematose, bunions, prominent metatarsal hairs because of the pes cavus. Then you also have the deformities which occur because of the Charcot's. Then you also patients will present with partial foot amputations. One of the things that we always miss in diabetic foot is the equinus. So this is the equinus which causes the transfer of pressure to the forefoot, and that's how the corns and ulcers and the big callosities would occur in the forefoot. and of course the foot drop per se. Now, what's the intrinsic minus foot? Basically, if you have to see the foot in diabetes, it has multiple issues. One is the neurological issues because of the microneurovascular dysfunction. Then the vasomotor dysfunction due to AV shunting, so there's a lot of slushing of blood. There are changes at the capillary basement membrane with altered capillary exchange. Glycation of the matrix protein makes this tissue very, very unhealthy. Loss of sweating function, poor ischemia, and the deformities per se. All this would cause a problem for the diabetic foot and make it prone for ulcer. The fat pad that is underneath the forefoot, under the ball of the toes, that tends to move away and then again makes the chances of ulcer formation very high. Defective footwear causes poor offloading of the pressure. So what are the ingredients of a diabetic foot ulcer? First, we need to know that 10% of them, the diabetic foot ulcer, 10% of them have diabetes mellitus. 25% of the DFU may need amputation. This is a statement that you need to remember. The main ingredients of a DFU are neuropathy, angiopathy, and immunopathy. When I said immunopathy, it means basically the leukocyte function is also compromised because of this issue, and then healing is a problem. And fourth one is ignoropathy, is ignorance of the medical field as well as the patients, which allows this ulcer to progress. It is also very important that we need to devote more time in examination of the contralateral limb, because if one limb is affected, definitely down the line, next leg is definitely going to affect it. So you do not just treat the ulcer, but treat the patient as a full. These are some of the high-risk pathology. You can see the calluses and the cons, and the pressure points that you do. At this stage, you have to be very, very aggressive in treating these patients. So what would you do to an ulcer like this? What it just needs is offloading. Now, the offloading can be done by using orthotics, or you can use surgical methods to offload. So let me come to that later on. On the clinical evaluation of DFU, first you have to visually inspect the ulcer, the size, location. As I said, there's this nice mnemonic that I noted, SINBAD. We should look at the site, look at ischemia, look at neuropathy, bacterial infections, area, and depth. So depth assessment of the ulcer is extremely important, because if the ulcer is bone deep, the chances of patient having an osteomyelitis are extremely high. Put a finger on the pulse, look at the vascularities, look for the skin changes, which you get in ischemia. Check the temperature of the skin, because if you have a sharper foot, you're going to have slightly warmer temperature. Look at the patient's gait, look at the intrinsic minus foot, look at the shoes, and do a detailed neurological examination to detect neuropathy. In any ulcer, these three things are important: extent and depth of the wound, presence of ischemia, and presence of infection. Any one of them present always complicates the issues. That's why this University of Texas classification is one of those classifications you can use, very, very functional classification, because it takes care of the fact that every ulcer may be infected, not infected, could be ischemic, not ischemic, and that would change the plan of treatment. So what are the principles of management of a diabetic foot ulcer? As I said, the primary thing you need to do, other than taking care of the ulcer, is to offload the ulcer. The offloading of the ulcer, as I said, can be done using orthotic, or you can change the pressure on the foot by doing a lot of surgical procedures. Infection control has to be done rapidly in patients who are having an active infection. Either you have to use intravenous antibiotics or oral antibiotics based on the bacteriological culture sensitive report. Improve the blood flow. Many a time, before you even attempt an amputation, if you can improve the blood flow by doing a angioplasty of the lower limb, which the vascular surgeons do nowadays, it's worth doing that, because it has saved a lot of limbs. Correction of deformity is an extremely important step in management of the diabetic foot ulcer, so that it doesn't recur. One thing, once you correct the deformity, it heals the ulcer, but also prevents further occurrence of the ulcer at the same site. Optimizing the levels of blood, lipids, and blood pressure is also important. Control the comorbidities and stop smoking. Now, the offloading, the International World Group on Diabetic Foot gave a few recommendations. Now, offloading should be done with an orthotic on a neuropathic, non-ischemic, non-infected wound. So if the wound is infected, and if it is ischemic, then you need to be very careful when using an offloading orthotic. Now, what is the ideal offloading orthotic? It should be knee high and it should be non-removable, like a total contact cast. If that is not possible because of the presence of an ulcer and you're worried about it, then you can put the patient on a cam walker or a cross splint or a removable knee height or an ankle height offloader. Removable orthotic is important, especially in the infected exudative ulcers. Otherwise, you can also use footwear with felted foam and toe spacers, which is the last choice, but in terms of the hierarchy, it really is not as effective as the total contact cast. So total contact cast is the gold standard of offloading orthotic. Surgical offloading, as I said, is possible by TA lengthening, by flexor tenotomies, by metatarsal head resections. Multiple surgeries which correct the deformities also act as surgical offloaders. This is a typical dirty ulcer which came to me. It has been treated for 6 months, or maybe more than that, and 3 months old after that it's come there. After 1 week of doing an ostectomy or a exostectomy, I just put this patient on a Charcot type of a crow type of a spleen with an unloading orthotic. After 1 week of ostectomy, this is the situation. Just simple saline dressings and silver dressings, 2 weeks post-op. And gradually this ulcer shrunk and healed completely in a matter of weeks. And this is what the patient was wearing with a small insole. Now, this is as simple as that. It really doesn't, there's no rocket science here. You just need to understand that every ulcer needs to be offloaded. If the ulcer is superficial, debride it to bleeding margins, use a moist dressing. Simple saline dressing is good enough. Oral broad spectrum antibiotics. If the ulcer is deep, then you debride it till you have removed all the dead tissues. Drain the deep abscesses, because in diabetes, the infection travels along the compartments. You can use a hydrocolloid on the alginate dressing for a wet ulcer. Use parenteral antibiotics for deep ulcers, and think of revascularization of these deep ulcers, because they're not going to heal as much as the superficial ulcers. Every week you need to evaluate the ulcer. You look at the depth, degree of exudation, degree of infection and ischemia. This has to be assessed on every ulcer every time you open the wound. Now, as far as the type of ulcer dressings are concerned, there are various types. If it's a moist gauze dressing, it just supports autolysis and exudate absorption. It is good in most of the cases. Using the hi-fi hydrocolloid, hydrogel dressings, calcium arginate dressings, they have not really shown to be better than a simple saline dressing. Keep the wound moist. That's what the wound wants. If it's an exudative wound, you could use something like calcium arginate. Sulfur sulfatazine, bexitracin, zinc, neosporin, and cadexome or iodine are very good. What you should not use in diabetic wounds are hydrogen peroxide, povidone iodine, the dikine sodium hypochlorite solution, acetic acid, because this destroys the ulcers. If the healthy ulcers, do not use this. Special agents used in delayed ulcer healing, you can use platelet-derived growth factors, collagenase enzymes, but again, really no good evidence. VAC dressings, large, huge cavitatory wounds, you could use a vacuum assisted closure. Pulse lavage can be used in a very, very dirty wound. ESWT has been used for non-responding ulcers for more than 2 weeks with reasonable results. And hyperbaric oxygen therapies in chronic ulcers after failed revascularization is worth giving a chance. So when did you suspect osteomyelitis? 15% of the diabetic foot ulcers will have osteomyelitis. Do a swab, dip it into the wound, see how deep it goes. A large ulcer greater than 2 centimeters square, deep more than 3 mm, and an elevated ASR is a key that something is wrong, something is much bigger. And a probe to the bone is a definite osteomyelitis unless proved otherwise. And here, these ulcers, they need to be investigated further by doing an imaging study to detect osteomyelitis. Go to do an MRI, look for any collection, deep collection. MRI is very good at picking out deep abscesses. Control of infection, as I said, oral broad spectrum antibiotics are enough in most superficial infection. It is important, but to drain those deep abscesses and open out the dead spaces, trim the ulcer margins, decompression of the compartments, parenteral antibiotics for deep infected ulcers, and give a broad spectrum gram-positive and gram-negative cover and obligate anaerobe cover, because 80% of the time it is staph and strep and proteus, and very rarely you get the gram-negative ones. In culture-sensitive reports, give more specific response. Now, in any ulcer, if it's not healing beyond 2 weeks or 3 weeks, you have to think that this is just not a neuropathic ulcer. There could be a component of ischemia. So you need to do an air pressure, do an ABI, do a toe pressure measurements, look at the transcutaneous oxygen measurements, and any ulcer which is not healing at 6 weeks, you have to think of ischemia. And before contemplating above ankle amputation, you need to try and do a revascularization procedure, which helps in many cases. Coming to the shock of foot, it's a progressive non-infectious neuroarthropathy. It can either occur because of the repeated trauma, or basically could be an abnormal vascular blood flow. So Charcot foots can present in three situations. One, immediately after fracture fixation, when the fracture just collapses and you wonder what happened when you fixed it so well. So this could be the beginning of Charcot's in an ankle fracture. The patient could present with an acute Charcot foot, which looks like an infected foot to start with, but it is not infection. Or you can have a chronically swollen foot with a midfoot collapse, with a small non-healing ulcer. So these are the three scenarios where you can get a Charcot foot. You have to be basically able to tell a Charcot foot just based on the skin temperature. There's a huge, significant difference in temperature of a Charcot foot. X-ray is the primary investigations. You can do an MRI to find out for any deep infections if are there. A total contact cast and a closed splint are the basic treatment to offload them. And once you have offloaded the ulcer, if there is a big exhaustectomy to be done, do that, remove any projections, realign the bone, try and get as much as realigned. You might have to do a lot of resection and stabilize by using something called as super construct screws, because it is never enough in a Charcot foot. The longer the span of fixation, the longer the plate on both the sides of the fracture or the collapse will be enough, never enough to stabilize a Charcot foot. And Charcot foots, even if you achieve a fibrous healing, it does give a functional foot. In diabetic foot surgery classifications, there are 4 classes basically. One is the elective surgery that is done in patients to reconstruct who do not have loss of sensation. Then you do a prophylactic reconstructive surgery in patients who have a LOPS but do not have a wound present. So again, prophylactic. Curative is once you have a diabetic foot ulcer, whatever surgery you do on them in open wound is curative. And lastly is the emergent, like compartment syndrome, deep decompression, amputations, radical debridement. These are the 4 types of surgeries that you see in diabetic foot. So what is the purpose of corrective surgeries? First, it is to unload the forefoot, so that once you've unloaded the forefoot, and that can be achieved easily by doing a TL landing or a gastroc recession, because it reduces the forefoot pressure, and you have to be able to achieve at least 10 degrees of dorsiflexion in a normal foot so that the forefoot pressure is normal. What are the other procedures that are done? One is the percutaneous distal metatarsal diphyseal osteotomies, which can be done percutaneously. Then you can do a TAL and gastroc recession, which is offloading procedure. Percutaneous tenotomies of the flexor tendon to prevent the clotos from getting abnormal pressure. You can also do a pan metatarsal resection. Resecting usually one head and leaving the others unremoved. The moment you remove one head, the ulcer will shift to the other one. So generally, you try and do a pan metatarsal resection. You can also resect the first MTB joint in a callus. You sometimes need to do midfoot resections in a collapsed Charcot foot. Midfoot and hindfoot arthrodesis in Charcot foot of the hindfoot, exhaustectomy, and finally, if nothing works, definitely amputation does help to relieve. These are some of the surgeries we can see here. This is the foot with a collapse. This typical Charcot foot here. You can see the X-ray. Then the big exhaustectomy. Simple exhaustectomy helps to heal the ulcer. A gastroc recession done here, along with an exhaustectomy, will help to heal these ulcers. You can also do a metatarsal head resection to decompress the first MTB joint. Pen resection can be done if you have multiple ulcers like this. External fixator frame to construct and achieve a planticket foot is a good way of looking at it. And finally, amputation. So these are the different types of surgeries that you can do. There's a saying, carry your feet as your face, or you will bury your feet before your face. This really puts the treatment of diabetic foot in a very nice way. Now, when do you basically look at amputation as an option? If there is an extensive tissue loss, intractable infection, or non-reconstructible occlusive disease, these are the ones which will never heal. 5 out of 6 amputations occur in diabetes. 50 to 70% of the non-traumatic amputations occur in diabetics. The commonest amputation that you do would be a ray amputation or a small toe amputations. But eventually, if the vascular problem cannot be solved, then transtibial amputation is the preferred one, as it gives the best prosthetic fit. Aggressive control of infection and distal revascularization of the calf and foot arteries can prevent amputation in many, many cases. Poor functional recovery after major amputations has put in the argument that try and save the foot as much as possible because the care can never be the same without the foot. In summary, again, it is our responsibility as orthopedic surgeons to save the diabetic foot. We have to take it on us as the owners. And how do we do that? We do an integrated and continuous service by a team approach. We need to set up a team in our hospital. You don't have to do it yourself, but at least train your staff to look at them, educate them, do the wound care, set up protocols yourself, early identification of the pre-ulcer lesions, educate on the foot care and early referrals, early intervention. Don't just procrastinate and call them later on. Don't treat a foot ulcer like a back pain. That is generally when a lower back pain patient comes to your clinic, you say, oh my God, another back pain. I don't know what to do with this. This sort of an attitude with a diabetic foot is only going to make matters worse. Offload your ulcer as soon as it comes. Treat the infection and ischemia aggressively. Correct the deformities. An orthopedic surgeon, it is your duty to see that you provide the best plantigrade foot. And that is the only way to prevent amputations and also simultaneously treat the comorbidities. So in my final take-home message, don't treat diabetic foot with a defeatist attitude. Catch them young and go multidisciplinary. Train the staff for education and ulcer care. Offload it either by an orthotic or by a surgical correction. And amputation basically indicates that there is a failure of healthcare. Thank you very much.
Nice talk. I think Shantanu is not here. So it was a wonderful talk, Mahendra. And if we have any questions regarding it, or Shamshul is listening to us, he can take the charge, how he has to proceed further. I don't think so. We are the only ones who are left here. So, so there is no one from the organizers. So, and
I would just like to say this thing to Mahendra sir. It was a really nice talk, sir. Because I guess the real success in diabetic foot is to limit the number of surgeries for the patient.
Yes.
If you know how to do that, that's a success.
I think the real thing is that instead of trying to grab the patients from the general surgeons and say that we are going to treat the foot, we need to create a team in our hospital. All of us have a general surgeons, all of us have orthotists. It is just that we need to sit together on a table, own your protocol, and see what happens to every diabetic foot that comes. What is the pathway? This pathway is extremely important. Create an SOP for this diabetic foot. Like if you see the nice guidelines, they have given every step they have given a proper protocol. How often you have to see them, what should be seen, and you don't have to do it yourself. You can train a nurse or an operation theater boy to take care of the dressings. You just have to refer the patient to an orthotist and say, okay, offload this guy. He will do this job. Yeah. The problem is we approach it in such a way that we just treat it like another wound. It's not another wound. It's not a surgical wound. It's a diabetic wound. So you have to address the ischemia. You have to address the neuropathy. You have to address the infection. And only after you offload it, is it going to heal, just like a normal wound. Right. So I think that's what we need. We shouldn't just put it behind. We just need to take it forward. Thank you.
I don't think so. There are any questions in the chat boxes, so we can.
Yeah, we could wind up for the day.
We can say goodbye to everyone whosoever is.
Concluding
I would like to thank
Dr. Mahendra.
Yes.
So we are looking for a concluding remark from Dr. Mahendra.
Okay, right. Thank you. I would like to thank each one of you, starting from Dr. Rajiv Vora. He was the opening batsman, made a fantastic presentation on ankle fractures, which was so well presented, giving the real perspective of especially what an average orthopedic surgeon shouldn't do and how he looks at the ankle fracture in a three-dimensional view. You did a great job. Rahul, you also presented very well the calcaneus fractures. I think we all need to fix our calcaneus fractures the correct way. And there's only one correct way. There can't be multiple correct ways. So we need to master that correct way of doing it. and followed by Siddharth, as usual. He was so precise in his tailor fracture presentations. Always a pleasure to listen to Siddharth. Then followed by Malhar. It was a very off the beat topic, because you really don't get to see so many cuboids and navicular fractures. But when you find them, you need to treat them properly again to maintain the length of the foot on the medial and the lateral side, and that's the key. And finally, Apna,
Shantanu.
Dr. Shantanu, Lisfranc is something that we just can't afford to miss. A small miss of a Lisfranc is going to create a havoc in the life of the patient. So we have to be constantly alert on that. And as far as my talk was concerned, it was more of creating awareness about diabetic foot. I'm sure all of us know how to treat a diabetic foot ulcer. It's just that we need to get our thinking process right and get those protocols right on the table. And I would request all of you to go back and set a diabetic foot clinic in your own hospital so that they get the required care. And thank you very much once again to IOA for giving us this opportunity for IFAS. And we wish RC Mina and his team and Dr. Shamsul Hoda a very big success in the coming conference, despite all the COVID situation. And we will support the cause of IOA and the cause of IFAS always. Thank you very much.
Thank you. Bye.
Thank you and good night.
Just
Bye.
to add, sir, IFAS has a physical session also in the upcoming conference on 6 from 11:30 to 1:30. Unfortunately, we have a clash with APOA foot and ankle. So Dr. Mahendra sir could not come there. So, but yes, Dr.
On the
Ravinder Rana and Mahendra Shah would be there.
Thank you. Yeah, they're going to be.
We are all involved in APOA, so it will be very difficult for us to.
Right,
I have two sessions there, so.
Right.
Okay, guys, take care.
Okay.
Thank you.
Bye.
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 Good night, everyone.